Okay, to begin category 3, we're going to do the psoas analysis. So take the patient's hand from above the head, traction just a little bit, place the hands together, show him into a prayer position. I can see that his right side is short, so we'll put the hands down. I would go to his left side. I would contact the right psoas, the belly of it, using a flat forefinger contact. At the same time, I'd have the patient bend the knee. I would externally rotate the knee while they inhale. Upon exhalation, I would internally rotate the knee while applying pressure to the belly of psoas. And each time I did this, I would go a little bit deeper, and I could treat this 3 to 5 times. Okay, go ahead and have you face down, please. Next is the prone leg length analysis, where while the patient is prone, I would take their feet, I would move them about 14 inches apart. I would have them resist against me pushing inwards. I would then compare the medial malleoli of each leg and see that he is a left short leg because the left medial malleolus is shorter. Next is going to be the glute fiber analysis. Glute fiber analysis is where I take the PSISs, label them as area 5, then going up around the crest, I could label them 4, 3, 2, and 1. So starting, I would, on each side, I would move around and ask the patient which one is tender. For the sake of the argument, we're going to say that the third area was tender, and it was most tender, so that's also good. The same thing on the right side. Third on both sides. Was the left more tender than the right?
Yes.
Okay, so the left side is the most tender of that one. Okay, like I said, tender point was left side, L3, which correlates in lump brother principle up to C3. So on the patient, I would come in, I would find C2, I would find C3, and now I would palpate on the TVPs and the spinous. The TVPs of the cervicals relate to the spinous of the lumbar, while the spinous of the cervical relates to the mammillary of the lumbars. This would tell me if I had either a rotational or a wedge slip on my on that lumbar vertebra. Next would be the indicators, which would be a number of them. We would just be checking for taut and tenderness upon palpation. That would be going from the calves, the hamstrings, the glutes, the paraspinals, and lastly, could you turn your head to the right side, please? Lastly, we'd be looking at the temporosphenoid line, and those would be our indicators for a category 3. Next would be SOTO, or shoe up, toe out. What we would do is take it's for a sciatica patient, we would take the affected leg, so for example, if he had sciatica on the left side, we would take his leg out about 14 inches. We would then externally rotate the foot. We'd hold that for about 10 to 15 seconds. We'd bring it back in. We'd wait 2 minutes. We'd repeat that process, asking what the patient felt changed. If it felt better, that would point to a piriformis issue, and we could treat using that shoe out, toe out method every 2 minutes until it was fully subsided. If it got worse, that would point to a sequestered disc, and if there was no change at all, that would point to a subluxation or a herniated disc. Next will be CAT3 blocking. And what we're going to do for CAT3 blocking, I get my blocks. This is a passive treatment, or passive assistance to treat for pain that can be done for up to 30 minutes. You can see I had a short leg. On that short leg side, I'd internally rotate, I'd find the greater trochanter, and I would put the blocks facing inferiorly at a 45-degree angle. I would then go to the other side. Again, this is a passive insertion, so I would treat at the ASIS with the block facing inferiorly at 45 degrees, and I can treat them like this up to 30 minutes. Okay, now that we've blocked for category 3, we're going to start with the posterior iliofemoral ligament. We're going to do that by coming to the patient's feet. We will grab proximal to the ankle and internally rotate on either side, looking for the area of most resistance. His would be on the left. In order to correct that, I would come to the left greater trochanter, go 1 inch superior, 1 inch posterior, using a double thumb toggle towards the opposite obturator foramen. Make that adjustment. Come back and recheck to ensure that the resistance has disappeared. Next is going to be the lumbar derotation. For this, I'm going to have the patient tracked on the table, so they would end up pulling up while I was performing this move. I would take the side of rotation, bend the patient's knee up with my inferior hand, contact the spinous process of the involved vertebra with my superior hand, and I would apply for 5 seconds lateral to medial pressure upon that rotated spinous to get it going back in the proper direction. Next one is also going to be traction. It's the treating for lumbar inferiority. So I would again involve side, traction on the table with the patient. I would take the involved leg, bend it up. I would contact the mantle area of the inferior wedge, and I would apply an I to S pressure for 5 to 10 seconds as I held that to decrease the wedge. Following all of that would be acetabular going. Next thing to do is to find the acetabulum, bend up the involved leg. I'm going to palpate around the acetabulum for nodules. Whenever I do find a nodule, I'll move the leg in small circles while maintaining pressure upon those nodules. Next is going to be orthopedic blocking. This is for spinous rotation. I would go to the side of rotation and I would remove the block, allowing that spinous to be rotated back into the proper direction. Finally, with that block in place, I'm going to do sciatic traction, and the indicator for this is sciatica. I would go to the involved leg side, and I would apply traction while the patient tractions the head of the table. I would apply traction for 5 to 10 seconds. I would repeat this until their symptoms decreased or disappeared. Okay, post-blocking techniques, there's 3 of them. Once we've removed the blocks, we're going to start off with sacral cupping. That means that we're going to stabilize one side iliac crest while the patient attempts to raise the opposite leg about 30 degrees off the table. They'll just go as high as they can. If they can't go any higher, that's completely okay. The doctor will apply pressure, and they will try to resist against that. They will do that on both sides while we're looking for weakness. Now, if we do have weakness, we'd go to the sacral cups, left side, apply pressure, and we'd retest all 4 of those areas for the upper and lower cups. Now, whichever one of those restored the strength in that leg, we would use that as a side to adjust. So we would go to that cup, we would apply pressure in a P to A motion for 10 seconds, and then we'd retest the strength to see if it was back. The next thing is going to be the seated disc maneuver, and that's going to be indicated by a disc issue. So the patient will be seated on the SOT pad. They would be seated facing away from the doctor. We would go to the involved vertebra. The patient would tuck their chin to their chest. We would go to the involved vertebra. The patient would bend forward while inhaling. The doctor will apply an I to S pressure on the spinous. Then they will exhale while coming back. The doctor will switch to the mammillary process, applying a P to A pressure. And we'll repeat this as many times as necessary until the pain is decreased. Okay, lastly for category 3 is we have the side posture maneuver. This is indicated by sciatica, and we will always put the sciatic leg downwards. Put the patient in side posture. We will take the superior leg. The doctor will put his hip into the popliteal fossa. You will have contact on the shoulder. Inferior hand will contact, if it's a rotational issue, will contact on the side of rotation on the mammillary process, and I will apply a P to A thrust through that mammillary process. If it was a wedge side slip, then I would contact, again, same area, but instead of applying a P to A pressure, I would apply an I to S thrust.